So we're going to continue our discussion of chapter 43, starting at the endometrium now and pathology that can be associated with that. Now, if you guys remember with the endometrium, it kind of changes how um, it looks throughout the menstrual cycle, depending on the hormones that are helping to grow the tissue and then the hormones that help to shed the tissue. So if you remember, there's two stages, proliferative and secretory of the endometrium. So the endometrial canal is a landmark for identifications of the long axis of the uterus. And on your test that you had, you could see on those images, transvaginal especially, images of a long strip of echogenic material, and that is what the endometrium is. And you guys did very well in recognizing that. Yep. So, like I said before, the progressive thickening and increased reflectivity of the endometrium occurs in majority of patients until the shed during menstruation. And it's very important is it should be measured perpendicular to the long axis of the uterus, and calipers should be placed at the maximum anterior to posterior diameter of the outer borders. So when you're in a sagittal view of the uterus, that is where you want to measure the endometrium from anterior to posterior. There is sometimes a hypoechoic area around the endometrium called a halo, and you should not be measuring this because it's just part of the myometrium. So you want to make sure that you are just measuring the echogenic portion of the endometrium. If there's any fluid, it shouldn't be included in the endometrial measurement. I usually measure the fluid and then I measure the endometrium. So some pathology of why the endometrium could be extremely thick. Now, I know that our cutoff is 14 millimeters of endometrium. If it's greater than 14 millimeters, it's considered a thickened endometrium. So these are some reasons why it could be abnormally thick. In early pregnancy, if a patient has gestational trophoblastic disease, endometrial hyperplasia. Some patients get thicker endometriums in the secretory phase, greater than that. And there's not necessarily anything wrong, but they're greater than the cutoff of normal. So you'll just want to mention that. If a patient's on estrogen replacement therapy, if there's polyps, or if endometrial carcinoma. So a lot of these pathologies do cause clinical symptoms such as abnormal bleeding, especially endometrial hyperplasia. If there's a polyp in the endometrium or carcinoma, the patients are definitely going to have bleeding. Now, one of our major signs that we need to get the endometrium is checked out is when a patient is postmenopausal and is having bleeding. That since endometrial cancer occurs later on, usually in postmenopausal patients, it's one of those things that we just want to make sure that the endometrium is not too thick, because that would be the first indication that there could be some kind of cancerous thing going on. Disorders of the endometrium may also occur in menopausal patients with breast cancer receiving tamoxifen therapy. Now, tamoxifen is a drug that helps with patients with breast cancer, but it can make the endometrium extra thick and hyperplastic with little cyst areas, and usually that occurs because of the hormones that tamoxifen creates. So sonohysterography or a saline infused sonography, that is one of the ways that we can evaluate a very thickened endometrium. Now, most of the times, ultrasound is not too much involved in these. The doctors usually do them, yet they do use ultrasound to evaluate these. I don't think if you're in the hospital, you're going to be performing these procedures. But what the doctor does is puts fluid into the endometrial canal with saline, and that um, you're able to see the inside of the endometrial canal better and to look for growths or polyps. In premenopausal women, we want, these are usually performed around day 6 to 10. So there's not a possibility of pregnancy yet, but no bleeding is occurring. In postmenopausal women, procedure can be performed at any time. This procedure they do not want to do in patients with acute pelvic inflammatory disease. And usually no special patient prep is needed for this. So this is a image, like this is a transverse uterus image, and you can see that the endometrial canal is filled with fluid, but there is a large mass that is seen, and it just is so much well defined than if we didn't have that fluid around there. So that's probably a large polyp. So let's talk about a little bit about endometrial hyperplasia. Sometimes it could just happen from extra estrogen stimulation. It could be a precursor to endometrial cancer. And what it is exactly is just abnormal thickening of the endometrium. So patients are coming in with heavy periods, menorrhagia. A lot of the times, if there's not a polyp in the endometrium, you're still going to see that the endometrium is extremely thick, probably around 2 centimeters, and that could be a possible reason why the patient is having heavy bleedings, because the endometrial tissue is just grown beyond what it should, and it's not getting shed as it should every single month. So a lot of the times if it is very thick, they can do a D&C where they go in and remove some of the endometrial tissue under anesthesia. So let's look at here. This is a great image of a uterus here, and then how you measure the endometrium from anterior to posterior. So this looks like the secretory phase. And look at this beautiful picture of a transvaginal ultrasound. And you can see the 3-line phase. This is the proliferative phase. And look at how they measured it there. Now, both of these appear normal, and they're not giving the measurement, but just by eyeing them, they appear normal in just different phases of the endometrial cycle throughout the month. A majority of women with postmenopausal uterine bleeding are experiencing endometrial atrophy. This is what I want you to know. A normal postmenopausal endometrium is less than 5 millimeters. If they're having irregular bleeding and a thickened endometrium, they might warrant an endometrial biopsy where they'll take some of the tissue just to make sure it's not cancerous, or a sonohistography to just see if there's not any polyps. A lot of the times I'm going to see a patient that is having postmenopausal bleeding and their endometrium is going to be greater than 5 millimeters, and that could be just some hyperplasia going on, but they'll want to make sure that it's not a start of any kind of carcinoma or cancer. So this is ultrasound. Ultrasound can be used to help clinician triage which patients are candidates for biopsies. If the endometrium is 5 to 8 millimeters in a postmenopausal patient without bleeding, they could potentially still do the biopsy. But if it's less than 5 to 8 millimeters with bleeding, they could also do the biopsy. So it kind of depends on the clinical symptoms. Usually with postmenopausal bleeding, with the doctors I work with, they don't hesitate to do an endometrial biopsy just to check and make sure the tissue is okay. So look at this, how much thicker this is than what the uterus itself, um, the uterus in the previous slides, these. Look how much thicker this is. This is probably about like a 3 centimeter, 4 centimeter endometrium with some vascular flow. And this could be endometrial hyperplasia or the start of endometrial cancer. So they'll want to make sure that they are checking this out by doing a biopsy to just make sure that there's nothing else going on besides just increased endometrial thickness. A little bit about common hormonal regimens for menopausal women. It's just good for you guys to know just a little bit about this, because you will want to ask when you are doing a postmenopausal lady what if they are on any hormones, because it will change. They'll have a thicker endometrium if they are on hormones. So number 1, no hormones. Number 2, unopposed estrogen, usually Premarin. This will cause a thicker endometrium. Could be a potential for endometrial hyperplasia or carcinoma. This is, they'll do estrogen and then they'll do progesterone. Is another hormone regimen that they do for menopausal ladies. And then this is the last one, sequential estrogen and progesterone. So if they're on these, their endometrium is going to look different than if they are just not receiving any hormones. So menopause is just a big pain, is what I've heard from my mom. So I've had to see her go through all these hot flashes and these horrible symptoms. So I can understand why menopausal ladies would like to still get hormone replacement therapy, just so that it can alleviate some of the menopausal symptoms. And these are some of the benefits. Hot flashes, night sweats, and painful intercourse are some menopausal symptoms, and estrogen can help to relieve that. It reduces the risk of osteoporosis, hip fractures, and vertebral fractures, and reduces risk of heart attacks and strokes. Progesterone, the benefits of that are it reduces the risk of endometrial hyperplasia and cancer, and produces endometrial atrophy. So they kind of can work together. But always, nothing is just good, right? Like there's always a negative side to a lot of things. And the negative side with the estrogen is it can increase your endometrial hyperplasia and cancer risk. Well, progesterone, taking that can increase the risk of breast cancer and cause irritability, depression, breast tenderness in women. So you have to kind of outweigh the benefit versus the risks on taking these hormones. Endometrial polyps, we've talked about a little bit, but a lot of these patients that have these polyps could be asymptomatic, and a lot of them don't even know they have them. If they're large enough, they could present with some uterine bleeding. Polyps are overgrowths of endometrial tissue covered by epithelium. So what you're going to see when you see an endometrial polyp is you're going to see a thickened endometrium, and then you're going to see like an echogenic distinct mass within the endometrium. Another thing that will help you define what that it is an endometrial polyp is usually I'll put blood flow on there, and I'll see the blood flow coming straight to the polyp. And a lot of the times you're really not supposed to have too much blood flow within the endometrium in a normal endometrium. But when there is a polyp, you'll see blood flow coming through the stalk. The sonographic findings of the endometrial polyp is they're most easily seen during the luteal phase or secretory phase. They're represented by a hypoechoic isoechoic region within the hyperechoic endometrium. Initially, it may appear as a nonspecific echogenic endometrial thickening, or it may be diffuse or focal and may also appear as round echogenic mass within the endometrial cavity. I feel like they're pretty easy to see. So this is the endometrium, and then there's this large mass here. This is what it looks like coronally on a 3D ultrasound. Endometriitis is inflammation of the endometrium, and the endometrial thickening or fluid may indicate endometriitis. It's basically an infection within the endometrium, and it's usually the first stage of pelvic inflammatory disorder. Sometimes endometriitis can happen after postpartum state. That's why they take your temperature after you deliver the baby, because they want to make sure that you don't, from delivering the baby, you don't get an infection in your uterus or endometrium. It also occurs with STDs. So endometriitis, like I said, is basically stage 1 of pelvic inflammatory disorder, and it's a conduit infectious spread to the tubes and adnexus. So if it's not taken care of with antibiotics, it can develop into stage 2, stage 3, where the infection goes into the tubes, causing a potential hydrosalpinx, which is fluid within the fallopian tubes, pyosalpinx, which is pus within the fallopian tubes, and potentially even a tubo-ovarian abscess, which is stage 3, stage 4, where there's a horrible infection between the tube and the ovary. The thing with endometriitis is the patient has horrible, intense pelvic pain. Most of the time when patients have pelvic inflammatory disorder, you can barely do a transvaginal on them. They almost jump off the table because of just the intense pain. This is endometriitis, a fluid-filled endometrium. And look at the vascular flow around there. It just is lighting up because of usually with infection, you have increased vascular flow. Usually the endometrium appears prominent, irregular, or both, with a small amount of endometrial fluid. So it could be irregular, it could be prominent, it could have some fluid in there. You kind of have to look at how the sono findings signs are and then associate with the clinical findings of how the patient is feeling. Like if they have a fever, they have a high white blood cell count, and their endometrium looks kind of funky and weird, they have a good chance of potentially, and they have some of they just delivered a baby, or they have a history of like chlamydia. You have to kind of put everything together to diagnose it. Enlarged ovaries with multiple cysts and endoscopic margins may be secondary to periovarian inflammation if the endometriitis is spreads through the tubes into the ovaries. So dilatation of the fallopian tube, stage 2 of acute pelvic inflammatory disease, PID, shows the fluid-filled tubular shapes and folded configuration and well-defined echogenic walls. A thickened tubal wall is 5 millimeters or greater, and that's indicative of acute disease. And we'll talk more about pelvic inflammatory disease later on in our book, but just to give you a little bit of a hint, and it talks about this in this chapter. So I want you to read chapter 43 and do everything, and it'll, you feel pretty confident in diagnosing a hydrosalpinx on your test. So what a hydrosalpinx it looks like is like a fluid-filled tube, basically, and it can be curvy and not just straight like a vessel. And when you see a hydrosalpinx, it's either chronic acute pelvic inflammatory disorder or like it's acute, kind of depends. Like I said, as the infection worsens from endometritis and it spreads throughout the pelvic system, paraovarian adhesions may form and fused inflamed the tube to ovary, and this is called a tubo-ovarian complex. If that does not get better, it could be stage 4, which is a tubo-ovarian abscess, and it appears just as a complex multiloculated mass with septations. These patients are very, very, very sick. And usually by this time they're in the hospital, they're getting IV antibiotics, and it's just nothing that you want to play with at all. So, and sonographically, what you're going to get is just this large hypoechoic, nasty looking mass within the adnexa. Here's some of the clinical signs: low back pain and fever, lower abdominal pain, dysmenorrhea, menorrhagia, sterility, which is just having trouble. You're going to have infertility problems if you get PID, most likely, and constipation. This is the weird looking endometrium. It's thickened. It has tons of vascular flow. It's irregular. It's hard to define. The patient's probably complaining of back pain and fever. Their white blood cell count is probably up. And the synechii, we could talk a little bit about it, are intrauterine synechii or endometrial adhesions. And it's found in women with post-traumatic or post-surgical histories. I see these a lot when I'm doing just like usually like a complete OB ultrasound, 19-20 weeks, where they're finding out what they're having. We're going through an anatomy survey, and they're just like look like a little band that runs across the uterus. If you have a lot of these little adhesions, it's called Ashman syndrome, and that can be a cause of infertility or recurrent pregnancy loss. So with these, you're going to see bright echoes within the endometrial cavity, but it's difficult to diagnose unless there's fluid distending it. So I think sonohistography is probably the best way to diagnose this. The synechia is more easily seen in a gravid uterus, which is pregnant uterus, where they appear as hyperechoic band traversing the uterus and anterior to posterior. When I do a 19 to 20 week OB and I see one of these, I always like to mention it, although most of the time the outcome is good. Okay, endometrial carcinomas. Real quick on this, it's the most common gynecological malignancy in North America, and it's mostly in postmenopausal patients. The most common clinical presentation is uterine bleeding, although only 10% of women with postmenopausal bleeding have endometrial carcinoma. I'm sorry that I don't know why that did that, but it has a very strong history of estrogen therapy, hormone replacement therapy. So if you're taking estrogen, you have a higher chance of getting this cancer. In premenopausal women, patients that have polycystic ovarian syndrome and have anovulatory cycles, meaning they're just not ovulating and they're not having normal menstrual cycles, the endometrium gets bigger, thicker, and thicker and thicker, and that can be those patients can be high risk for endometrial cancer later on. Obesity is also considered a risk factor. So the first thing that can hint you off that it could be potentially an endometrial carcinoma is thickened endometrium. Sono findings, transvaginal examinations helpful in screening for early changes in endometrial hyperplasia or carcinoma by accurately measuring the endometrial thickness. So you're going to get a patient and you're going to have tons of ladies come in postmenopausal and having some bleeding. And what they'll want to do is do an ultrasound to see how thick the endometrium is. If the endometrium is thicker than 5 millimeters, then they will do an endometrial biopsy to see if there's any kind of tissue that is cancerous. This is a thickened endometrium again. Looks kind of like the same thing as our pelvic inflammatory disorder pictures. But it's difficult to tell the difference, except this patient, if they're postmenopausal bleeding and their endometrium is 2.94 centimeters, they have a much higher chance of this, and look all this vascular flow, that being endometrial cancer instead of endometriitis, right? So you gotta kind of look at which patient you're looking at. This is another image. It looks like there's fluid and some possible clot within this endometrium. So next, if first thing's the endometrial thickening, the next thing that you might see is it getting very, very hard to see the borders of the endometrium because the cancer has invaded the myometrium. So transvaginally, it demonstrates myometrial invasion as thickening and irregularity of central endometrial interface with echogenic or hypoechoic patterns combined with infiltration hyperdense structures. Endometrial carcinoma is associated with estrogen stimulation, and clinically, it's going to be postmenopausal bleeding. It's most likely going to be postmenopausal when patients have endometrial cancer. Our sono findings are endometrial complex, enlarged uterus, irregular areas of low-level echoes, thickened endometrium with vascular flow seen within the endometrium. Some cancer may obstruct the endometrial canal, causing fluid-filled uterus, endometrial or hematometra, which is blood. If you're having trouble seeing the exact distinct borders between the endometrium and the myometrium, that could be a cause or a sign that the endometrial cancer has invaded the myometrium. Tamoxifen, which is used with the breast cancer like we talked about, has a secondary effect on the endometrium, causing these kind of thickened endometrium with cysts, kind of looks like endometrial carcinoma. But that's why it's important that you also ask if they're on tamoxifen or hormone replacement therapy, anything that could change how the endometrium looks. It's so important. Sometimes you can have a little bit of small endometrial fluid and it's not too hard, or I've seen this quite a bit. Sometimes if a patient has just gotten done bleeding, they're going to have a little fluid in their endometrium. Other causes would be if there's an ectopic pregnancy, endometriitis, a degenerating myoma, or a recent abortion. So this is pretty normal to see. Actually, I see this quite a bit when patients are kind of having abnormal bleeding. There's just some fluid, looks like a little bit of clot within the endometrial canal. This patient could have endometriitis if they're having pelvic pain and some of those clinical symptoms. They could just have got done bleeding. Sometimes when you're still in your menstrual cycle, your endometrium can kind of appear like this. That's why it's important that you ask when the last menstrual period was. Large endometrial fluid collections should be regarded with suspicion. The obstruction of the cervical os results in accumulation, secretions, blood, or both in uterus. So when you see that and you see like a very large fluid collection, It's called, it could be, it depends on where, how old the patient is. But you remember we talked about cervical stenosis in a patient that is older, and that is not letting the fluid or the blood through, and so it accumulates within the uterus. If a patient is very young and has an imperforate hymen, they're going to accumulate hematocrit blood and fluid because the blood and fluid can't get out of the vagina. If a patient has endometrial cancer, same thing could happen. So there's multiple reasons why there would be large endometrial fluid collections. When this happens, the patient typically complains of abdominal pain and a large abdominal mass. They may or may not have vaginal bleeding depending on where the obstruction is. So the patient will undergo surgery, usually D&C or dilation, this word, and they will just be able to take that out, and a lot of the times they can help alleviate the symptoms. Pyometra, where there's pus within the uterine canal, is more likely to be uterine cancer. So with large endometrial fluid collections, you're just, well, you're going to see a fluid-filled endometrium. That's basically what the sono signs are going to be. It could be echogenic if it's pus or blood. If it's more like fluid, it's going to just be more anechoic. So this is the vagina, cervix, and then this is the uterus. Look how full that is of fluid. Our last thing that I want to talk to you guys about are intrauterine contraceptive devices, IUDs, and you will be checking for these a lot. One of the things that I do quite a bit when I work are IUD checks, just to make sure the IUD is correctly placed within the endometrial canal. And what an IUD is, there's multiple different types. There's a Mirena, there's a Paragard, there's some contain hormones, some don't. It depends on which IUD they get. But they're devices placed in the uterine cavity during menses for purpose of birth control, and proper placement verified by patient with weekly digital palpation of string and cervix. Now, if they don't feel their strings, that's when they'll want to come in and get an ultrasound just to make sure that the IUD is still in the correct place. A lot of the times, the string is either fallen off or retracted into the uterus, and the IUD is still correctly placed. But it's one of those things I really want you guys to be aware of, because you're going to be doing these a lot. Sonography is really good for looking at malposition, perforation, or incomplete removal of the IUD. So a lot of the times, or eccentric positioning. So a lot of the times I'll see that the IUD was not pushed into the endometrium in the fundus of the uterus as much as it should, so it's hanging out in the cervical canal. So I would like to let the doctor know that. Other times they can not be in the right position within the endometrial canal, and other times they can even be perforated into the myometrium. So the Paragard is the T-shaped flexible plastic wrapped in copper. Those are so easy to see because they're copper, and the ultrasound just lights up. So they appear very echogenic. Mirenas are T-shaped flexible plastic, and they're still easy to see, but they're not as bright as a Paragard. This is a 3D of the IUD, and you can see here's the endometrial canal here, and the IUD is coming, one of the arms is extending into the myometrium there, so that is not correctly placed. This is what a Paragard looks like. And I love 3D ultrasounds for this. If you get lucky enough to be in a place that has a 3D transvaginal probe, you are so fortunate. I used to be able to work with, I worked at a place that had it, and it just makes looking for these IUDs so easy, because usually we only have the transverse and the sagittal plane, but with the 3D, we're able to see this beautiful coronal plane, which is so easy to see. Look at the T-shaped. This is the endometrial canal, and you can just see the IUD just directly placed, just perfect. Most of the time, we just have to rely on what we see sagittally and transverse, which it works most of the time, but this is just such a great image of the coronal view of the uterus with the IUD there. So what you want to see is the IUD when you're just doing a sagittal and transverse scan, which is most likely what you're going to do most of the time. You want the IUD to be almost to the tip of the endometrial canal in the fundus. This is the cervix here, and you don't want it down there. That means that it hasn't gone all the way. So you want the IUD right in the middle. Oh, that's it, guys. Okay, so why don't you guys write on a discussion about any questions you have about this part. We'll have a test next week over all of chapter 43 and a presentation due. So I hope you guys have a good week. Thanks so much.